Well, welcome everybody to this training webinar on destigmatizing wellness communications. We are so excited about today's conversation and really glad you've joined us. We're covering a lot, but we're going to post this in the meetings and materials section of our webpage in about a week, so you will have access to all of the materials and the recording. Before we get started, let me introduce the team. I'm Kristen Steimanoff. I'm the Washington Wellness Program Manager, and we have 4 health promotion consultants on our team who each support a specific employer group. Heidi Helsley supports public employers, Erin Huff supports state agencies, Mandy LeBlanc supports higher education institutions, and Aubrey Bright supports schools participating in SEB. And we also have some of our colleagues from Limeade on the call. Heather Barrick is a customer success manager at Limeade. Sarah Bell is a senior employee experience specialist, and she's been embedded with our program since SEB started in 2020. And Jamie Wise is also an employee experience specialist at Limeade who's been with our program for almost a year, since last October. Jamie is on vacation in Portugal today, so she's not with us, but all 3 of them are very much a part of our extended team. Here's what we're going to go over today. Mandy's going to kick it off when I'm done with the intro with a bit of an evolution of wellness communications. And then Katie Trend from the Department of Health is going to talk to us about destigmatizing tobacco cessation communications. I am going to introduce the topic of avoiding weight stigma in wellness communications. And then Beth Riphagen from Omada is going to talk about evolving communications related to diabetes. And at the end, between 11:30 and 12, we're going to have an optional networking session. Maria Royal from Washington State University is going to kick that off for us. And we really hope that you can stick around and join us. We hope you'll learn a lot. By the end of today's webinar, we hope you're going to walk away with at least these 3 things. We hope you feel comfortable using supportive and respectful messages to promote tobacco cessation. We hope you can talk about at least 2 ways that you might be able to avoid weight stigma in the wellness communications that you put out to your groups. And we'd love for you to understand how strengths-based empowering language can improve your communication around diabetes prevention and enhance the well-being of people who are in diabetes prevention or diabetes management programs. Quick housekeeping notes, as I mentioned, we will be putting all of these materials, including the recording, on our meetings and materials page. So this is being recorded. If you're not comfortable with that, feel free to exit now and check things out in about a week. We're going to ask everyone to hold your questions until the end of the presentation. We have the chat function turned off for now, but save up your questions, jot them down, and feel free to pop them in the chat or come off mute at the end when we make that possible. And we're going to try to answer as many questions as we can by the end of this presentation, but remember, we have that 30 minutes additional networking, so we can get into a lot deeper QA stuff then if you're able to stick around. I'd be remiss if I didn't put in a quick reminder to share information with your coworkers about our PEB and SEB wellness benefits. The diabetes prevention, the living tobacco-free program, and Smart Health are all included in employee benefits. And for folks who qualify, they are available at no cost. But we have a lot to cover. So now I'm just going to kick it right over to Mandy LeBlanc.
Thank you, Kristen. My name is Mandy LeBlanc. I'm here to kick us off with the evolution of wellness communications. And first, I just want to say, if anybody's looking for the closed captions option, if you go into your Teams, you'll see 3 dots in the upper left right-hand corner. Then click on More Language and Speech options, then turn on Live Captions. Thank you. I'm going to give a brief history of company wellness programs. Taking a look at generations ago, humans had plenty to worry about, but didn't necessarily focus on communications as much about wellness because, in general, physical activity was hunting and gathering, seeking shelter. Nutrition was from plants and animals. Sleep was mostly from sunset to sunrise. And so stress was prevalent. I want to focus on that it was just in a different way. Moving forward, as we get to 1926, Ford Motor Company started the 40-hour work week to be a bridge of ensuring safety and productivity. A lot more company wellness programs started around the 1960s, where large companies provided employee fitness centers. In the late 1900s, opportunities for social support and safety, such as the Employee Assistance Programs and Occupational Health and Safety Administration, launched. And then it really took a big tick up in 2020 during the pandemic when the Employer Health Benefits Survey, where 81% of employees were offered a corporate wellness program, 11%, an 11% increase from 2008. So I think the pandemic really made this way more focused. And then you'll see some more resources there at the bottom that we'll put in the meetings and materials page. Moving on, wellness programs, when I first started back in the early 2000s, were a big focus on hydration and taking the stairs. Oftentimes there was somebody that was put in charge of ordering some water bottles with the company logo and encouraging people to take the stairs if possible, as a way of focusing on health. And it was a gentle start into the world of well-being at the workplace. We then moved into a big Know Your Numbers campaign for a lot of companies, focusing on knowing your health numbers, which included height, weight, body mass index, blood pressure, etc. While some of this information is important, it can also be off-putting or stigmatizing. Body mass index is not always a reliable indicator of individual health status. The current and future trends focus on a holistic hub, focused on personalized well-being, reminders for annual preventive exams, including dental, making the best use of employee benefits, and connection to mental health resources. As I mentioned in the last slide, there has been a shift to focus more on mental well-being, from covering employee assistance programs, tips for stress management and self-care, as well as a connection to additional mental health resources. Also, please keep an eye out for our next training, October 18th, that we titled Mental Health Tools You Can Use. Historically, there was a belief that scare tactics and fear were effective communication styles. However, providing hope and normalizing health behaviors and a new path is becoming the norm in order to be more inclusive and welcoming. I first noticed this when I was at Seattle Public Schools, and I recognized that this is your brain on drugs message, and was told by the CDC and Seattle Public Schools Communications that actually it tends to be more effective when we can focus on positive and giving people something to show that it's actually normalized behavior that most people don't use significant drugs. So we've also provided some links providing more detail on that below, and those we put in the meetings and materials pages as well. It's important to get leadership support. So leadership support is critical to the success of our wellness programs. There are specific ways to earn support, such as how it can help manage healthcare costs, retain top talent, increase presenteeism, increase productivity, increase job satisfaction, and more when we have a strong program with ongoing leadership support and clear communications. Thank you for that, allowing me to do the brief introduction to wellness communications. I'm now going to toss it over to Katie, who will take it away with tobacco cessation and ensuring that wellness communications are as gentle and supportive as possible. Take it away, Katie.
Thank you so much, Mandy. Good morning, everyone. My name is Katie Trend. I'm actually the Comprehensive Cancer Control Program Coordinator here at the Washington State Department of Health. I'm going to just go through a little bit about how we can destigmatize communications about tobacco cessation. Next slide, please, Mandy. So after today's session that I'm going to be going over, you should have a better understanding of, why stigmatizing tobacco actually hurts rather than helps us prevent commercial tobacco cessation. Who are the folks still using tobacco? I'll provide you just a little bit of Burfist data to give you an example of who's still using tobacco in our state, and a few tips and examples of how to destigmatize your communications and your language related to commercial tobacco cessation, and some resources for promoting the Washington State Quit line. Next slide. So I wanted to start with what I think is an obvious question, which is, does it help smokers if we stigmatize them? And I'd really love to think that everybody on this call, considering your roles here in these different areas, would know that the answer is no. And in general, people know that smoking is bad for them. It's why it's often so difficult for people who smoke to seek help in trying to quit. But something I just wanted to reiterate is that messages that frame smoking as a moral failure or a failing of someone who does smoke, or that they are deserving of disapproval, are unlikely to lead to positive change. And there's actually science that supports that. And when you receive these slides in the notes, I have some of that science linked here for you. But people might be playing a role in their stigmatization or in the language that they're using. And so I just wanted to call out a few different examples of how we can use our language for positive change rather than adding more to stigmatization of tobacco cessation. Next slide. So stigmatization leads to a number of different things. And again, I have all of these linked here to the science that supports it. So stigmatization can lead to emotional, cognitive, attitudinal reactions that make people less likely to quit. It can prevent smokers from consulting doctors. It can create social isolation, which I think is a big one when we're talking about what's still considered a best practice, which is to create smoke-free workplaces and environments for others, which is still a great way in order to prevent tobacco use, but can also lead to the stigmatization. So if we're going to go these routes, how are we going to reach people is something that you want to think about. Perception of the deep divide between smokers and non-smokers. Some smokers do not even announce their quit attempts in advance, in part to avoid that stigma associated with failure. And while the evidence is limited, there is some to suggest that stigma may reduce willingness to truthfully report smoking or to seek treatment for smoking associated illnesses. So if we're going to reach people in terms of supporting their quit attempts or to encourage their commercial tobacco cessation, we need to understand how our language can lead to some of these different areas that even further stigmatizes the smoking population. Next slide, Mandy. So I just wanted to give you a little bit of an overview of who still uses tobacco. And there's a couple of reasons why I wanted to go through this. Approximately 10.8% of Washington residents still smoke, and this was taken from the 2020 Burfist data. I know recent data has just come out, but I haven't had a chance to put this up here on slides. But this is still relatively close in terms of understanding the disproportionately higher rates of tobacco use amongst people who identify in these different areas. And so I just wanted you to take a look at some of the examples that I have here in their rates of tobacco use, including American Indian Alaska Native, Black people, LGBT communities, people who are on Medicaid, people who have annual incomes of less than $35,000 a year. What you can see, and what I would hope that is resonating with you right now, is that these individuals also experience stigmas unrelated to tobacco cessation. And you can imagine that when you live a life that you're already receiving different stigmas related to other health issues or the lifestyles that you're living, when you're talking about commercial tobacco cessation, it can feel even more out of reach when trying to successfully quit for the long term. And so it's just a reminder that people are more than just their smoking status, and we should really remember that there is a likely underlying reason why someone is still smoking. Next slide. So one thing I wanted to make clear is that we need to make effective and sustainable support possible. There's some really easy ways to do this. And again, I'm hoping that some of this is again something that you know already, but maybe just need that extra encouragement to make sure that your language matches what is necessary when we're trying to reach this population who is still using commercial tobacco. So one of the things that is really successful is just acknowledging the challenges, acknowledging the addictive nature of smoking and the challenges that come with quitting, as well as the general attitude about smoking in our society, and how that can lead to limited quit attempts or struggles to try to follow through with quit attempts. We can enhance our communication efforts by just simply framing with empathy and prioritizing your audience. Again, thinking back to some of the numbers I just showed you about who still smokes. I'd like to think that, again, this is another obvious point, but using cultural and linguistically appropriate materials is critical. One of the things that you've heard me talk about is reframing, instead of just talking about tobacco cessation, really leaning hard on the idea that we're talking about commercial tobacco cessation, because especially for a community like American Indians and Alaska Natives, there are absolutely sacred tobacco uses that we shouldn't be infringing upon, but we should really be identifying and calling out, how we can support from commercial tobacco cessation, which is really what we'd like to support everyone on in this journey. And so, reminding people that it's not a moral failure, that people are motivated to quit. Ask yourself, what barriers could this person possibly be experiencing, or the communities that work in my area are experiencing, and how can we help reduce them to make quit attempts more possible? Next slide, Mandy. So communication is key. Remember, it's hard to quit. When you're thinking about what your relationship is to this person, this can also help with understanding how to destigmatize your language. Sometimes when we're sending out mass emails or communication campaigns, there might not be a direct opening to talk to somebody about that, but I am going to give you some tools on what that looks like if you are talking to somebody one-on-one, which I think will also help you, again, destigmatize your language and feel more confident when you're talking about these issues, again, when you're creating materials or trying to send them out to wide-ranging audiences. Obviously, don't lecture, be patient and positive. We know that smoking cigarettes is a serious and complicated addiction, and that makes quitting smoking one of the biggest challenges many smokers will ever face. And there are some different examples that I'm going to share with you about how to, again, destigmatize your language. And with that, Mandy, I'll go to the next slide. So since the chat is closed, I won't ask you to put it in the chat, and I'd really love if you had a pen or a piece of paper close to you, or if you don't, at least think to yourself, I'd love for you to imagine that someone you care about is attempting to quit using commercial tobacco, and they say to you, my doctor really wants me to quit, but it feels impossible. And I'd like you to just take a minute or so to think through how you would respond to this. This would be a very common thing that I'm sure many of us have heard if you know someone personally who uses commercial tobacco, but it also might be something that people resonate with who work in your area or who might be receiving your communications about commercial tobacco cessation. And I'm just going to give you 30 more seconds to think through, write down what your response would be to somebody who feels like quitting is impossible, but they know that their doctor really wants them to, or maybe somebody in their life really wants them to. All right, Mandy, let's bring up the examples. So I'm just going to give you a couple examples of some ways that I would reply, or obviously put these slides together of some suggestions of how you could reply. And one of the things that I really like is to start with the acknowledgement approach, that quitting is hard, but I know you can do it. Have you set a quit date? Focusing on the support, on the aspect of you being there for their journey, even though you know it's difficult. Reminding them that they're not alone. And even if it gets tough, you'll be there for them. Quitting is the best thing I ever did. Let me know if you need any tips. This might be more of a resonating experience for those who have used commercial tobacco in their life. And again, just another way to help people feel less alone when it comes to trying to quit commercial tobacco use. And I have one more thought experiment I'd like to go through. And with that, Mandy, please go to the next slide. One last opportunity to practice. And I just want you to imagine that a person that you care about says, I've tried to quit, but I couldn't get it to stick. And so again, if you have a pen, paper, please just jot down what you might respond to this or think it through of how you could support somebody who says, you've tried to quit, but just couldn't get it to stick. And I'll just give it a few seconds here. All right, Mandy, let's check out the examples. So here are some different examples of how you could reply to that. And again, there's no right or wrong way to do that. We're just thinking through how can we be supportive? How can we reduce that stigmatization and make people feel less alone in their quit attempts? And so I have a couple examples here that talk about, hey, slips happen. Don't beat yourself up over it. Like anything tough, you learn as you go, and you can use this as a time to restart to get back on track. Or something to the effect of, so you slipped. Quitting isn't easy. Again, reminding them and acknowledging how difficult it is. And many people need several tries before they quit for good. You've got this, and I'm here for you. And let's talk about what's triggering you to smoke. Maybe that will help you stay on track this time. Just don't smoke that next cigarette. And again, that's a little bit more of a forward approach if you have that door open. But just thinking through some of these ways that you might talk to someone one-on-one might help you be able to destigmatize your language and your communications when you're sending out information about how to stop smoking commercial tobacco or using commercial tobacco products. Thanks, Mandy. So just some reminders of some of the things that I've said. Putting yourself in their shoes and seeking to understand people, ensuring that it's a good time and a location. Again, I know often we are tied to only certain avenues in which we share our health communications with people, but I think it's important that we remain realistic and curious. And so sending out information about commercial tobacco cessation without really understanding who is going to be receiving this and is it really a good time and place, it just might fall flat. And so reminding yourself to be calm and patient and listening to the barriers or digging in deeper to who the communication campaigns are going to be reaching and to understand what barriers they might be experiencing and how we can reduce them. First conversations should be brief. Again, this is if you're talking to people one-on-one or having that sort of direct access to communication with somebody who smokes, you're really planting seeds. And again, this can also be used when you're talking about widespread communication of planting the seeds of hope and positive change, that this isn't something that they have to go through on their own. And opening the door for ongoing conversations. Maybe this is a difficult task, again, when you're simply sending out mailers or different wellness activities that you're engaging in, but always thinking with this framework when you're creating these campaigns, I think would be really helpful. Asking how it might make them feel. And, did people expect to get hooked? What do they think about the costs of tobacco? Some of these are different ways that you can think about commercial tobacco cessation when you're framing your campaigns to better, destigmatize these communication campaigns and outreach to these communities. Next slide, Mandy. So when in doubt, we have a really great resource here in Washington State, which is to send people to the Tobacco Quit Line, which is, again, just one avenue in which they can receive support on their commercial tobacco cessation journey. But there's some other really great resources as well, especially from people who are uh, employed through the state agencies who have access to healthcare benefits that maybe others who work outside of state agencies don't have. But this is a really great resource, a catch-all for anybody to utilize when they're on their tobacco cessation journey. And so we've got this information here for you as well. And I think we're doing question and answer afterwards. So thanks, Mandy.
Wonderful. Thank you, Katie. That was wonderful. And it flows nicely into the next topic, which is a few minutes to talk about avoiding weight stigma in wellness communications. And we started on this journey because earlier this year, Kim Concepcion, who is the wellness coordinator at the Washington State Department of Health, many of you know Kim, she approached us to ask if we'd be willing to look at how weight stigma might show up in our own program's messaging, particularly in Smart Health and the Diabetes Prevention Program. So we met with an internal work group at DOH that's been really focused on this topic. And Megan Saichi was part of this work group. Megan is a registered dietitian nutritionist, and she was at the time in the process of finishing up her Master of Public Health program at the University of Washington. And Megan proposed focusing her capstone project on providing a framework that would help our program and the Department of Health assess both existing messages and develop future messages that would be free of weight stigma. So we are very early in our learning journey, but I felt like today's webinar was just such a perfect opportunity to share with you what we've learned so far. Megan has generously provided some slides, so I'm going to go over those for the next few minutes. And then I think Megan's going to join us during the discussion, so that'll be a nice chance for many of you to ask more questions and pick her brain directly. So next slide. Wonderful. So what Megan has put together for us today is a brief primer to introduce you to what weight stigma is, what it looks like, and how to remove it from wellness and health promotion messaging. Of course, this could be a full day-long training, and I've had to trim it down even more to fit with the other topics we're introducing today. But at the end of these slides, you're going to have access to excellent resources that will help you further your learning. So to start off, I think it's really important that we connect our common goals in doing this work. And I'm just going to take the liberty of assuming that we are all doing the work broadly in wellness and specifically learning about destigmatizing wellness communications, because we want people to experience well-being. We want people to feel like they have access to good resources, and we want people to feel empowered to find and use those resources. So as we start talking through this, think about how weight stigma might get in the way of these goals of ours. Okay, I'm going to get us on the same page by sharing a few key terms before we dig in. And the first one is weight stigma. What is it? It can include a lot of things. It can include negative attitudes and beliefs about larger bodies. It can include negative stereotypes about larger bodied people. It can include devaluing people based on their weight. It might include other forms of bias, of discrimination, and of social exclusion. And it really can impact everyone across the spectrum of body sizes, but it most significantly tends to impact people who are in larger bodies. It can lead to a lot of negative outcomes. It can lead to increased risk of healthcare utilization, increased risk, of healthcare avoidance. And this is really connected to something that Katie mentioned about stigmatizing tobacco use. If people feel stigmatized because of their weight or tobacco use or any other factor, they are going to be less likely to seek care. This, in part, can lead to things like increased risk of chronic disease. It's sort of paradoxical that stigma against something that many of us have taken at times at face value of something we should be talking about, but stigma can lead to increased risk of avoiding healthcare and increased risk of developing chronic diseases, reducing people's willingness to actually get involved in health supporting lifestyle activities like group exercise. Again, if someone feels stigmatized, they're going to be less likely to go into those spaces. So weight stigma can lead to a lot of negative outcomes. You can go back to that other slide for a second, Mandy, thanks. Weight bias is a specific preference for thinner bodies or bodies with a lower body mass index. And then a trauma, sorry, all of a sudden Echoing. Okay, that's better. Trauma-informed approach. I can't go into it much today. It's beyond the scope of our work today, but it is an important foundation for moving away from weight stigma in our work. And this approach acknowledges the need to understand a person's life experiences in order to deliver effective care or provide effective support. So trauma can result from life events or circumstances that someone experiences as harmful or threatening, and it can have long-lasting negative effects on a person's well-being. So while we don't have time to dig deep today, there is an excellent resource on the last slide, and you can dig deep on your own. Before we move on to the next slide, I want to make one more note that is not listed here, but this work is really important to our work around diversity, equity, inclusion, and belonging. The state of Washington has prioritized DEIB, or some people say DEI, some say EDI. DEIB is the acronym I'm hearing a lot these days. Many of our agencies have prioritized this, and making sure we aren't excluding people due to factors including body size is vitally important. So now, how does weight stigma show up? So now that we have an idea of what it is, we're going to talk about how to spot it. And the table you see here is a really brief excerpt from Fiona Willer's recently published Weight Stigma Heat Map tool. There's a link to this in the resource slide at the end. And this tool was developed to identify how weight stigma shows up in public health and health promotion materials. And this is the framework that we're hoping to use to identify stigma that might show up in our own materials. But the tool identifies 10 different themes, and you see those down the left-hand column. These themes include criteria that help us assess where messages fall on this continuum of anti-stigma, which is a good thing, to weight stigma, which is the thing we're trying to avoid. And then this table also gives examples of each of the themes. So I'll go through them rather quickly. But the first theme is imagery, and it's really about negative images, negative depictions of larger bodied people. The next theme is high body mass as a problem. So materials that really frame a higher BMI as unacceptable or abnormal. The next theme is weight modifiability. So materials that present weight or body size as a readily modifiable chronic disease risk factor. The next theme is weight loss equals health. So really framing weight loss as a pathway to health. The next theme is overgeneralizing and misinformation, and this can take lots of forms. The next theme is weight equals dietary habits, and it often shows up as really demonizing certain foods or nutrients based on an assumption that they lead to having a higher weight. The next theme is weight equals physical activity. So really both assuming that physical activity is good and that if someone is in a larger body, they are sedentary. The next theme is mental health and cognitive capacity. So this is really the inference that someone with a high body mass is someone of lower intelligence or has cognitive defects of some sort. Then there's an environment frame. This is really framing the need for having social or physical environments that are going to lead to populations that have a lower BMI. And finally, a financial frame, citing financial costs of healthcare for a person with higher body weight as being a justification for focusing on weight loss. So those are the themes that Megan really thought deeply about as she was looking at lots of materials, and that we'll be thinking about as we look at different materials. And I encourage you to think about them yourself as you put stuff out into the world. But here's an example. This is a brochure from the Obesity Action Coalition, which interestingly has a segment of their work devoted to weight stigma and not using weight stigma. But even with the best of intentions, we can inadvertently have weight stigma in our materials. So I'm going to read this aloud just in case you can't easily read it yourself or you've joined us by phone. And as I read, I want you to read along or listen and think about where some of those weight stigma themes that I just mentioned might show up. This brochure is about understanding prediabetes and excess weight. So it starts with a question, and the question is, how can someone with excess weight and prediabetes reduce the risk of developing type 2 diabetes? And then the answer is, having prediabetes exposes an individual to a higher risk for type 2 diabetes. However, this doesn't mean that everybody with prediabetes will eventually develop type 2 diabetes. Studies have shown that the risk of developing type 2 diabetes can be reduced by losing 5 to 7% of body weight through diet and increased physical activity. So think about where you think those themes might show up that sort of show a weight stigma or sometimes we refer to it as anti-fat bias. Okay, next slide. So if you spotted the phrase excess weight and the sentence, studies have shown that the risk of developing type 2 diabetes can be reduced by losing 5 to 7% of your body weight through diet and increased physical activity, you got it. These messages imply that weight might be a problem that needs intervention. They present weight as readily modifiable, easily changeable, and they assume that dietary choices and or physical activity are going to impact your weight status. If you just eat the right things and move the right amount, you're going to lose the weight. So we can ask ourselves if including weight in this context is stigmatizing, what could we replace it with? How could we make it less stigmatizing? So then in the next slide, Megan has sort of changed it up just a little tiny bit. We do know that reducing the risk of developing type 2 diabetes is an important health goal for everybody, especially those with elevated risk. But we can focus on messaging that doesn't reinforce weight stigma. In this case, we can remove weight-related messaging. It makes the resource more trauma-informed, less stigmatizing, and more impactful. So what we've done here is just taken out the mentions of weight. How can someone with prediabetes reduce the risk of developing type 2 diabetes? Or you could go a little deeper. You could say, how could someone with risk factors or prediabetes reduce the risk of developing type 2 diabetes? And then that becomes a conversation with a healthcare provider or a deeper analysis. And then the answer, having prediabetes, can you go back? Exposes an individual to higher risk for type 2 diabetes, but this doesn't mean everyone will develop type 2 diabetes. Studies have shown that the risk of developing type 2 diabetes can be reduced through diet and physical activity. You can promote those healthy behaviors without having stigmatizing messages about weight. So this is just one possible example and just a really good opportunity to think about things which on the face of it might seem very benign. Now you can go to the next slide. These are the wonderful resources that I keep promising you will have access to. So when you do get access to the materials in about a week, I really encourage you to explore them. And then this is Megan's contact information. She is so smart and so open and so willing to talk. And so if you want to reach out with her, I absolutely encourage you to do so. But with that, I'll turn things over to Beth at Omada.
Perfect. Thank you for that background, Kristen, and for all the work you, Kim, and the Washington Wellness team did on weight stigma to date. I think that really bleeds well into this next portion of our conversation. So hello, everyone. My name is Beth Riphagen, Customer Success Manager here at Omada, supporting large organizations like PEB and SEB in bringing our diabetes prevention program powered by Omada to your organization, and again, partner very closely with the Washington Wellness team on a daily basis just to make sure we're bringing this benefit forward to those that want to take advantage of the solution. The goal of my section will really be to showcase the evolving communications about diabetes, prevention, otherwise known as the DPP, that is available to covered KP and UMP members. And I'll note for Premera Blue Cross members, they have different programs available, the diabetes prevention program powered by Livongo. But with that, OMADA being a diabetes prevention program, let's provide a quick history of diabetes, which many of you may already know this information, but it really helps ground ourselves into why OMADA is an organization in place today and helps us understand the impact ahead. There are two types of diabetes, type 1 and type 2 diabetes, that are chronic diseases that affect the way your body regulates blood sugar or glucose. Glucose is really the fuel that feeds your body's cells, but to enter your cells, it needs a key, and really that key is insulin. If you have type 1 diabetes, your body makes little or no insulin, and it's your immune system that attacks and destroys cells in your pancreas that makes insulin. If you have type 2 diabetes, the cells into your body don't actually use insulin properly, and so the pancreas may be using insulin, but it's not making enough insulin to keep your blood glucose levels in normal range. And you can help prevent or delay diabetes, knowing the risk factors and taking steps towards a healthier lifestyle, which we'll discuss through today's conversation. The second bullet, there is still no cure for diabetes. However, newer drugs and an awareness of possible causes have really improved the outlook of people with this condition. And these are newer drugs plus lifestyle behaviors, which can be a true key to success in properly managing your condition. And diabetes isn't new. Over about 3,000 years ago, the ancient Egyptians mentioned a condition that appears to have been type 1 diabetes. It featured some of the symptoms that we see with type 1 diabetes. So that includes excessive urination, thirst, and weight loss. And the writers recommended following a diet of whole grains to really reduce those symptoms. So that was 3,000 years ago, and we have since come a long way in really understanding type 1 diabetes and type 2 diabetes much further. So when we continue through today's conversation, if you go to the next slide, I thought now that we've talked about diabetes, let's really ground ourselves in pre-diabetes. And we can see the numbers on the screen really share here directly. 1 in 3 US adults have prediabetes. It's roughly about 33% of an employer population. Broken down further, that's about 96 million US adults aged 18 and over within our US healthcare system. And on top of those numbers, about 90% of people don't know that they are pre-diabetic because they aren't getting their common screenings. And on top of that, there are not really any symptoms for prediabetes. So how would a person know if they aren't getting those common screenings? So here we're really hoping to showcase that promoting a diabetes prevention program helps empower people to know their risk and avoid a path of progressing towards type 2 diabetes. Where OMADA fits into this is being educational. Knowledge is power in preventing the progression to type 2 diabetes, and this knowledge can not only impact a member who joins the program or a similar program, but also can impact a household at the end of the day. So the next slide, Mandy, let's next talk about ways to encourage and support members. And to showcase what we hear on the OMADA side, we actually pulled quotes and specific themes from HCA members as to why they joined the OMADA program and consolidated them into the themes below. So you really have visibility to the why when promoting a diabetes prevention program like OMADA. You can see here the first bullet, diabetes prevention programs encourage members to refrain negative thoughts, to focus on what they have control over. We know our lives are busy and there's many things that we don't have control over. Our days can sometimes get the best of us. And so our goal is, again, to really make sure we're reframing those negative thoughts and building positive small steps in a positive direction. The second bullet, use health coaches to support members bring awareness of choices, and help people make change possible. We realize that every single individual who joins our program experience is different. Every single individual who's on this line is different. And so that's why we feel as though it's really key, as mentioned in that bullet, to bring awareness of choice. The last bullet, diabetes prevention, aims to help members feel better both physically and emotionally via a new perspective on food and fitness. We want to make sure members look at the programs available as a whole person care program experience. So that's why we truly emphasize physical and emotional as a way to join a program like OMADA, and more importantly, get an impact out of a program like a diabetes prevention program. You can see here on this slide that weight loss isn't really mentioned. It's empowerment to feel better and prevent diabetes. And I'll note we actually got away from the term weight loss, as Kristen mentioned in her conversation earlier. Throughout our materials in partnership with the HCA, and that was to further destigmatize the negative correlation to weight loss or weight loss assumptions. And truly, at the end of the day, some people may not lose weight in a program like OMADA, but really the goal is to gain tools to live a healthier lifestyle. So the next slide will next talk about communication tips. And as for these communication tips, a task force of clinical bodies within our U.S. healthcare system that really put forth clinical standards for diabetes helped create communication guidelines. And many of these are known but reinforced. This will really help showcase that everyone is going to have a different level of health literacy. Some may fully understand diabetes and other may not. Healthcare and chronic diseases at the end of the day are very complex. And so let's dive into these tips. The first bullet mentions diabetes is a complex and challenging disease. Members of healthcare teams can serve people with diabetes more effectively through respectful, inclusive, and person-centered approach. Person-centered, I want to call that out here. One of the reasons why OMADA has health coaches as human health coaches and support behind the scenes. The third bullet, stigma that has historically been attached to a diagnosis of diabetes can contribute to stress and feeling of shame and judgment. So again, education about resources versus pinpointing someone because you know they have diabetes. And the last bullet, person first, strengths-based, empowering language can improve communication, enhance motivation, and well-being of persons with diabetes. I will note that there are recommendations for language and speaking the language of diabetes linked in the bottom of the screen in the slides that will be shared as a follow-up to today's conversation. So next we'll talk about tips for communicating about diabetes. And now that we've really learned how we can communicate, let's talk about those do's and don'ts. So do's. You'll see here, do use the term prediabetes. As for a don't, that falls in line with the comparison. Don't have a lengthy discussion about risk percentages. I know I use some of those percentages to help really frame the impact in our US healthcare system, but for your conversations, that can just be confusing to people. Another do ask for the patient's or members' questions, concerns, and feelings. We are people at the end of the day. Don't assume you know how the patient is reacting or feeling in the moment. You can catch a member on a good day, on a bad day, and we want to really be sensitive to a member's feelings within that mindset and within that day. Do emphasize the significance of having prediabetes, explain how it is different from type 2 diabetes. Again, health literacy, some people may or may not know prediabetes versus diabetes, and offer hope for preventing or delaying the diagnosis of type 2 diabetes. Ask what questions or concerns the patient has. Don't, so the comparison here, assume all patients will understand this message in the same way. We are all different at the end of the day. Some patients hear diabetes and experience immediate stress. Others hear only the pre and feel tremendous relief. But of these reactions, it makes it hard for a patient to listen and understand the remainder of your message. So 2 more do's here that I'll read. Do include other older adults, as a key target group, encouraging them to make manageable lifestyle changes to prevent diabetes. And another do emphasize that lifestyle change promotion used in the NIH-sponsored DPP was effective for all ages and all ethnicities that participated. So the comparison here, don't assume older adults won't make lifestyle changes because of their advanced age. We actually do studies on older populations that join our program experience and have seen tremendous results. And last, don't exclude groups that you think may not benefit as much. So again, inclusivity at the end of the day, encourage all those regardless of age and ethnicity. My last slide here before passing it back will be to emphasize health literacy. Again, I know I mentioned this. We all have different understandings as to what diabetes and what prediabetes is. And so we want to make sure we're communicating based off the understanding that health literacy may be different, especially emphasized on the last screen where we went through those do's and don'ts. Health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Healthcare is overwhelming, and we want to do our best to communicate it properly and clearly. For people, when we talk about health, as we can see here, it does have a direct impact on motivation, role and engagement, behaviors, management, and well-being and outcomes. So again, thank you for letting us go through this portion of today's conversation with the diabetes prevention powered by Omada. We hope you walk away with some great understanding as to ways to newly communicate the benefits that we reviewed today.
Thank you so much, Beth. I'm going to jump back to remind you of the learning objectives for this training. We're hoping that by the end of the training now, you will have used supportive and respectful messages to promote tobacco cessation. So knowing how to implement what you've learned from Katie. You'll be able to describe at least 2 ways for avoiding weight stigma in wellness communications, thanks to Kristen reading from Megan's slides. And you'll be able to understand how strengths-based empowering language can improve communication and enhance the well-being of people enrolled in a diabetes prevention program. It's now time to open up the chat where Kristen will insert the evaluation survey.
Still seeing the chat turned off, but I am poised and ready when Sarah's able to turn it on. There. All right, so this is, if you click on the word evaluation, it's a link to the evaluation survey. And your feedback helps us in so many ways. We really encourage you to take a moment or two right now to fill it out. And I think we have a few minutes for questions before we move into the networking. But as you look at the evaluation, there's the survey that we will carefully review. And if there's anything else you want to tell us, email Mandy. Her email address is right here at the bottom of this slide.
Are there any burning questions that you have to ask either in the chat or you can come off of mute before we join into the networking time? Give it another minute to see if there are any big questions.
Stacey Laney is saying, what about those tobacco pouches, the new Zins or whatever? Katie, can you field this one? You may need to ask for more detail.
Yeah, absolutely. Stacy, could you put in the chat, are you just talking about approaches to communicate about these? Smokeless tobacco, I include kind of in an umbrella of all commercial tobacco products. And so I would, use some of these same strategies when just talking to somebody who uses commercial tobacco products like pouches or dip is often called.
Someone said the evaluation link isn't working for them. That's a bummer. I'm going to try something different. It's not as pretty. Thanks, Olivia. That's a bummer. Mandy, if we may just need to send a message to folks,
Sure.
an email after the fact.
Sure. We'll be sending this out with a link to the recording, the slides via our meetings and materials page. And at that point, we can also send out the survey. No problem.
Yeah, sorry, the link's not working. We will get that to you, but not right now as we hoped.
We could jump to, unless there are any other questions. Any other questions in the chat before I toss it over to Maria?
No, we have a comment from Sonia Dordal, examples of how to destigmatize communications were very useful. Very glad to hear that. Lots of comments that the evaluation link doesn't work, bummer. Often I just pass, again, from Sonia on flyers from PEB initiatives. Will those be reviewed for destigmatizing language before they are sent to coordinators? Sonia, absolutely. And it is a learning process for us. We're learning. We're not perfect yet, but always aiming toward that. And we have made a lot of changes based on feedback we've gotten both from individuals in the PEB program and wellness coordinators. So we always encourage that feedback. If you spot something that you think is stigmatizing, please reach out and tell us. We really want to improve. And good, Megan, thanks for putting your email right into the chat. That's Megan Saichi, who has so much knowledge about weight stigma, and she's very open to outreach. So take her up on it. And feel free to copy me. As I say, we're learning and want to continue the learning. Anne says, very good information on these topics. Changing language and addressing the stigmatizing aspect is so crucial. We agree. We're glad you feel that way. That's why we're doing this. Beth, here's a question for you. Does Omada still give out scales? I remember signing up years ago and got a scale, and the program was focused on weight.
We do. Thank you, Kristen, for the question. So one of the tools that we provide is that cellular connected scale. I know this conversation is around destigmatizing weight loss. And so if a member doesn't want to utilize the scale within their program journey, that is completely okay.
We do find that it's an interesting balance that we have to strike between providing tools that a lot of people want and find useful and making sure that our communication about these issues is not turning people off and turning people away and making them feel stigmatized. So it's not easy, but it's worth doing. And Megan and others at DOH, when we first started this conversation, agreed with my concern that we not let perfect be the enemy of the good, and that we're going to take this journey and sometimes stumble and still try to get back up and continually do better. We're almost at 11:30. We're going to continue the conversation during the networking session, so we hope lots of you can stay. But if you do have to wrap, again, these things will be available in about a week from our meetings and materials page. Heidi, you want to pop that in the chat one more time? It's way up at the top now, and people might not have easy access to it, but Heidi put a link to the page where you can find that stuff when we post it. Thank you. Okay, so it's there. That's where the recording and the slides will be. And an agenda and a link to register for our next training, Mental Health Tools You Can Use, on October 18th. So with that, Mandy, shall we transition?
Yes. Now we'll jump into the networking time. And to kick us off, we have Maria Royale for Washington State University. Maria, do you want to take it away for a few minutes on how you've been able to apply what we've learned today at Washington State University?
Yes, thank you so much for all of this helpful information and for giving me the opportunity to kind of share about our approach here at WSU. I think, I can talk about specifics, specific terms we use and don't use, and kind of how we frame questions. But I think the most important thing is kind of a mindset check. And this can be kind of difficult as work in health promotion or the wellness industry, where you are kind of driven by metrics you should be meeting or numbers that need to be improving. When we look back at the this is your brain on drugs, the kind of scare tactics. Honestly, that's an attempt to take people who are not ready to change and force them into changing because of fear, right? But the way we run our program is making sure that we get information and resources out to people with an open door, so that when someone is ready, they know they can come to us and we're a safe place. Again, we of course don't use scare tactics, but if we're going to be addressing people who are, in the stages of change model, they're in pre-contemplation, they are not thinking about making a change, they're not really interested right now, we're not going to force that person into changing, but our place is to maybe move the needle a little bit. So, for example, if we're talking about weight-related communications, health that has usually been tied back to losing weight. First, before we speak at all, remember that losing weight is not good for everyone. I have dozens of anecdotes personally and with people that I've known of situations where gaining weight was a good thing for their health. So very important to remember that individuals have different lives, different health statuses, different conditions. Some of them are going through things and they can't possibly add paying attention to their health and weight right now. That's fine. But we want to be here when that improves. And more importantly, we want to help provide you with better support so that whatever it is that's taking your attention away from your ability to care from yourself, you have a path forward there. So for, avoiding weight stigma in communications, if we ever talk about weight loss or health or nutrition in general, it's kind of from did you know? Have you thought about this? We're heading into the holidays, and a lot of people come out of it feeling guilty. How can we help you prepare there? Did you know XYZ? If we talk about, diabetes prevention, to be honest, we don't really talk about that aside from the materials that we get from Washington Wellness and OMADA. But again, it's just informational. Fun fact, did you know, fill in the blank. Are you aware of your risk of developing diabetes in the future? Do you know these numbers? If not, here's a few ways that you can take one step today towards improving that. And then same with like tobacco related communications, no shame, no harm, no judgment we're putting on people for using tobacco, but have you been thinking about quitting? How did your last quit attempt go? We can support you the next time you're ready to try. Did you know that when you stop using tobacco, the first beneficial impacts that your body sees from that happen within just a couple of hours. There are hard things coming down the road, but know that even if you quit for a day, a week, that's an attempt and it matters and your body will thank you for it. So things like non-scale victories, we don't necessarily need to see that number moving, but do you feel better? Are your clothes more comfortable? What about pain that had been bothering you? Is that changing? If the number on the scale is a scary thing for you, you don't necessarily need to pay attention, because there are many things that go along with improving your health status, more far and beyond just a number on a scale. So really coming from a place of compassion, information, open door, we're going to meet you where you're at, never trying to force people into something they're not ready for. So that is kind of our approach here at WSU. It's slow moving, but I absolutely believe it's the most sustainable way to help people implement change.
Thank you, Maria. All right, but does anybody have any questions for Maria? Okay, we've got some networking questions. So feel free to continue asking Maria either in the chat or coming off mute. But I'll start with the first question, which is, how has your thinking changed about promoting tobacco cessation to your coworkers? Would anybody like to enter that in the chat or